you, Matthew. So, hello everyone. I am very pleased to have you all at the first TAPAS webinar. So, it will be held every Tuesday at 1. And as Matthew told, it will also be recorded and put on the TAPAS YouTube channel. And today we will have two presentations. The first one by Sebastião from Toulouse. It's about deep learning approaches to assess head and neck cancer voice intelligibility. And the second one is from Yilin Pan. She's from the University of Sheffield, and she will address using speech analysis to detect onset and monitor cognitive decline. So, Sebastião, you can start and share your screen. Thank you.
Okay, so hello everyone. I'll share my screen in a second. Okay. Okay, so I guess I can start now. So hello everyone. My name is Sebastião Quintas. I'm a PhD student in Toulouse.
Sorry to interrupt.
Yes.
I think something's blocking your slides, placing.
Here on the left.
Also on the top, there is something which is blocking.
Okay, probably.
On the right and the block, yeah. So thanks.
Thanks. I'll try to reshare it again. I think on the right is the minimization of the.
Yeah.
Okay.
Thanks.
Oh.
And share it properly.
Okay, does it seem better now?
Yeah, it's better.
It's better. Okay, I think it's from Zoom. Okay, so hello everyone. My name is Sebastião Quintas, and I'm here today to present the scope of my work inserted within the context of my PhD thesis on deep learning approaches to assess head and neck cancer speech intelligibility. And the title of this presentation today will be called Towards Reducing Patient Effort and Automatically Predict Speech Intelligibility for Head and Neck Cancers. So first and foremost, I'll just do a quick overview of the topics that I'll be covering throughout this presentation. I'll start by give a brief introduction on the topic of speech intelligibility within a clinical setting and why an automatic approach has been seen as a reliable alternative. Then I'll move on to the methodology, where I'll introduce the proposed model as well as anything that comes with it. Moving on, I'll start the experiments and results by introducing the C2SI corpus and the pseudo work task that's inserted within the context of the same corpus that was used throughout the ongoing work. Then I'll introduce the reference intelligibility measures based on perceived phonological deviation. And finally, I'll present the experiments and results from the proposed methodology. Moving on, I'll discuss a bit on the pseudo word reduction that will be more focused towards reducing the patient effort by using smaller quantities of data at inference time. And finally, wrap everything up with the conclusions. First and foremost, I'll introduce a bit what speech intelligibility is. It's a clinical measure used that is particularly important to assess the communication ability and voice ability of patients that suffer from speech impairments. It's normally used to monitor and track the progress of some patients in the post-surgery or in the case of neurodegenerative diseases that affect in a longer period of time the speech and phonation ability. It is known that these measures are inherently subjective since they are evaluated by health professionals such as doctors and speech therapists. However, each doctor has his or her own opinion concerning the measures at hand, and sometimes that causes a bit of lack of agreement on some patients, and the measures can be, for example, biased on previous patients that the same judge already saw that day, and so on. And given this, an automatic approach has been seen as a reliable, reproducible, and unbiased alternative that could counter the subjectivity associated to these measures, and also free the practitioner to perform some other tasks that are also highly important within a clinical setting. On the other hand, despite this, we know that automatic approaches tend to require larger amounts of data to operate properly, especially in the case of machine learning and deep learning. And in the field of pathological speech, there's not always a lot of data, and especially due to patients' fatigue, which is a common reason to leave recording speech tasks incomplete, we have less data to work with. So we need to make the best use out of the data that we have. Given this, for the present presentation, I propose two main objectives that we'll aim to tackle. The first one is to propose an automatic model that is capable of obtaining objective and reproducible intelligibility measures. And the second objective is to prove that the same system can still obtain high performance levels when using smaller amounts of data at prediction time. So now, after this brief introduction, I will pass to the methodology, where I will briefly introduce the proposed model that we used in the scope of the ongoing work. So the system is based on the transformer methodology with self-attention. Here I have a diagram that illustrates the pipeline that we used throughout this system. So as I mentioned before, we will be using a pseudo-word task. So as input to the system, we have a group of pseudo-words for each speaker. The words pass through a filter banks extraction box here that extracts 40-dimensional filter banks to be used as features. Then we pass through the first part of our transformer, the encoder, then the self-attention layer. Finally, the decoder part, the skip connection there. And then at the end, for each one of the input files, we obtain a score that corresponds to the intelligibility score of that same audio file, that in this case corresponds to a pseudo-word. Later on, if we want to obtain the intelligibility of a given speaker, we perform the mean of all of the scores obtained for each word, and then we therefore obtain the intelligibility score for each speaker. Now, after the methodology, I will dive into the experiments and results, where I'll first start by introducing the corpus that we used and the pseudo-word task that we used as well. So the corpus is the C2SI corpus, also called the French corpus of head and neck cancer. The corpus has a variety of recorded speech tasks that are widely common within the context of pathological speech, such as passage reading, spontaneous speech, sustained vowels, and so on. However, in this case, our focus was set towards an isolated pseudo-word task, where each speaker was asked to record a set of 52 pseudo-words that respect French orthography and pronunciation, but are non-existent in the French language. Each one of the 52 pseudo-word sets was different among the different speakers, and there were no repeated words. And each pseudo-word follows a structure as follows, where at the beginning we have either a single consonant or a consonant group, so two consonants in this case, followed by a vowel, a single vowel, and then another one of those clusters of either a single consonant or a dual consonant, and finally a second vowel. Here I have an illustration of an example of a 52 pseudo-word set. At blue, we have example of words that have a double consonant at the beginning of the word, and at violet, we have the same, but for words that have double consonant in the middle. There are 16 words that have double consonant at the beginning and 16 words that have the double consonant in the middle, and the overlap of the two leaves us 5 words with the 2 occurrences of the 2 types of double consonants. The structure of these pseudo-words will be highly important, especially in the part that we try to reduce the quantity of data used to make a reliable intelligibility prediction, but I will explain that a bit further on this presentation as well. So here I just added some pseudo word examples, just to give some context on the data that we're working with. We have here the audio files followed by the transcription. I added 3 different tiers of speech intelligibility. So the first one, we have a control, which is a high intelligibility speaker. Then we have a mid intelligibility patient, and then a low intelligibility patient, just to see a bit the differences that we can find between different types of speakers that are present in the corpus. And then here, for each one, I have just an example of a word without double consonant, a word with one occurrence of double consonant, and then finally a word with 2 double consonants. We'll just play some examples, hopefully you can hear.
Bama, Bifru, Flurma.
Okay, so from these 3 examples, with the transcription, we can, even if you don't speak French, you can see that somehow the characters and the consonants somehow correspond to the sounds that were being issued in the audio file. I'll pass on to the mid-intelligibility patients. Again, it's still easy to understand. However, we can start to see some deterioration in phonation ability, especially around the R, for example. But with the transcription, it's still easy to understand what was being said. And now for the low intelligibility patient. Well, in this case, we can see that some phonemes, for example, the consonant T was not being pronounced, and the articulation difficulties were namely found in the cases where we have a case of double consonant as well. And without a transcription, it was clearly hard to understand what was being said by the patient. So this was just to give some context on the data that we're working with. Now I'll introduce a bit the reference intelligibility measure that we used, because we need a reference intelligibility measure to train the system. And in the context of this study, this measure is based on the perceived phonological deviation, or PPD. It's a short version. This perceptual measure is obtained using a distance measure between the ground truth and the perceptually transcribed pseudo word. So I will explain this in a bit. Each pseudo word was transcribed by 3 different listeners, by naive judges, and the resulting distance mean is used as ground truth for each word. So how does this perceived phonological deviation work? For example, here we have the transcribed ground truth of a given pseudo word, and here we have the perceptual transcription by one of the judges, and then based on a cost matrix that has the distances between consonants and vowels, and the distance between these phonemes, we can form a path, and then using a Wagner-Fischer algorithm that works similarly to a dynamic time warping algorithm, we can find the shortest path, and the accumulated distance obtained from this path corresponds to the intelligibility measure. So a shorter path per se, or a low value in the distance, corresponds to a high intelligibility word. Corresponds to a word that was transcribed very closely to the ground truth, and a high distance, for example, the one here, in which the words have nothing to do with each other, means a word that was not well perceived by the judges. And then, since we performed that 3 times, the 3 different judges, the mean of the 3 different judges corresponds to the ground truth for one of the patients, for one of the word of the patients. Now, concerning the experiments and results, we trained our system with a 10-fold cross-validation scheme. We used a grand total of 126 speakers, out of which at each fold 113 were used for training, and the remaining 13 were used for validation. As a validation metric, we used both the Spearman's correlation and the root mean squared error. And we also compared our proposed model with 2 previous approaches. The first one was the baseline that worked very similarly to the process that I explained here, but instead of having the perceptual transcription, an automatic speech recognition system was used instead. And then we also use as reference the X-Factor speaker embeddings. That was also our previous work on speech intelligibility as well. So in this case, the results suggest that our developed model promoted a high correlation increase compared to the X-Factor, so 7%, and an increase of 15% when compared to the ASR baseline. So it's still a fairly big increase. And concerning the error between the X-Factors and our proposed model stayed fairly somehow similar. However, our proposed model promoted a lower error, but especially if we compare this error to the error obtained via the ASR approach, we can see that the error decreases to more than 50%, and therefore it's also a big significant decrement in the error. So now the first objective of this presentation that was to obtain a reliable model to predict speech intelligibility at word level. We can say that the results suggest that our model works well. And therefore, now in this discussion part, we want to assess the system's ability to work or to make accurate predictions using smaller quantities of data. So just to give you a quick reminder on the motivation behind this, recording a set of 52 pseudo words is a highly demanding task for patients, not only for patients that have severe speech impairments, but especially for them, since it's highly fatiguing as well. And therefore, it becomes relevant to assess how our system performs when using smaller quantities of data, in this case at inference time. So we did not train a new model with smaller quantities of data. We just wanted to assess how our system would predict intelligibility instead of using the 52 pseudo words, using a smaller subset. And in this particular context, we will focus on the system's ability to predict intelligibility based on the pseudo word structure that I explained previously. So the paradigm of having double consonants, the co-articulation between consecutive consonants and words without this occurrence of double consonants. And we will also follow a bit a line of research that's referenced here that proves that perceptually words that have a double consonant are better conductors of intelligibility than words without. So therefore, in this part of the present study, we want to perform a similar analysis on our proposed automatic measures to see if it would translate as well to the automatic domain and not only perceptually. So as far as the pseudo word reduction, we performed 4 different types of reduction that were based on the pseudo word structure that was issued previously. So the first 2 groups, we have the 2 sets of 16 words that have double consonants. The first one that only has double consonants at the beginning, and the second one that have double consonants at the middle. Then we have the set of 26 pseudo words that don't have any double consonants. And finally, we perform an assessment on the subset of 5 words that have double consonant either at the beginning and at the middle, which is the smallest subset. As far as correlation goes, we can see that compared to the reference from our model, the correlation decreases slightly. So there's a 2% drop in correlation. However, it stays fairly comparable, and it's not a big change in correlation per se. And as far as the error is concerned, for these 2 groups, the first set did not promote any change at all. And the second one, only a minor increase in the error as well. So it can also be seen as not significant. For the third set, using this reduction, we use the 26 pseudo words that corresponds to half of the original subset of words. And in terms of correlation, it also promoted a 3% drop in correlation compared to the full set, which is still a pretty much non-significant drop in correlation. However, we can see that the error starts to increase, which is interesting because we have 10 extra words in this subset than in the other 2 subsets, and we already see an increment in the error. Therefore, stating the power of the words that have double consonants when conveying intelligibility. So here we have around 30% of the original set, and here we have 50%, and we can see that these 2 30% groups work better. For the final set of 5 words that have double consonants at the beginning and at the middle, we almost obtain a correlation of 80%, which is a fairly high correlation concerning that we are only using 5 pseudo words. That corresponds to less than 10% of the original data. And in this case, we can see that the error, well, despite increasing a bit, it stays fairly comparable to the previous error achieved. And therefore saying that there's a high potential of these words to be better conductors of speech intelligibility than all of the other words as well. So now here, still concerned within the context of the pseudo word reduction, I just added the plots that illustrate how the correlation here on the left and the error on the right change when we reduce even further the different subsets. So we performed a random sampling on the groups of pseudo words. So here is the 16 pseudo words that have double consonant at the beginning, and we reduce them even further, right until 1. Here the same thing for double consonants in the middle, for words without double consonant and the words with the 2 occurrences of double consonant. And well, the curves both in correlation and in the error stayed fairly similar. The biggest drop in correlation was when we passed from 2 words to only 1. We can see almost a 20% drop in correlation here on all of the cases. However, what is quite interesting to see is that if we use only a single word to predict speech intelligibility for a given speaker, if we use the words that have double consonant at the beginning and at the middle, or even the words without double consonant, we have a base correlation between 40 and 50%. However, if we pick one word that has the 2 occurrences of double consonants, we start already with, in this case, given the random sampling, already with the base correlation of 60%. And this aspect showcases that, well, these words are indeed better indicators of speech intelligibility. Stating that with 1 word, we already have a base correlation of 60%, and with 2 words, so very small quantity of data to be used at inference time, we can already achieve a correlation of almost 70% and an error of 0.55, which would be considered fairly low, given the quantity of data used. So now we're almost done in this presentation. I'll just finish up with some conclusions and some perspectives on the subject. So concerning the results obtained, they suggest a high correlation and the low error when compared to previous approaches, especially to the previous baseline that was the one based on automatic speech recognition. Moreover, at inference time, we can drastically reduce the quantity of pseudo words used without affecting much the final score. This aspect was seen given by the 2 subgroups that have 16 pseudo words, so the ones with double consonant in the beginning and the ones that have double consonant in the middle, and also the final group of words that have the 2 occurrences of double consonants. And well, therefore, we can say that both perceptually, that was illustrated on the study that I referenced, and automatically, the presence of double consonants played a very important role in this part, and that this aspect, this reduction to 30% or even to 10% becomes crucial to avoid patients' fatigue during the recording of speech tests. And this leaves us some perspectives for future work, both automatically and also in a clinical setting. Stating that, for example, the creation of an even smaller list based on words with both occurrences of double consonant is an interesting lead for future work. For example, pseudo words that are longer in size, so instead of only having consonant, double consonant, vowel, another consonant cluster and vowel, we can add even more intricate consonant co-articulations or even consonant vowel or vowel-vowel co-articulations. And well, the possibilities, there are a lot of possibilities as well. And for example, in the creation of a new pseudo word test, we can put an order of priority. For example, the words that have occurrences of double consonants are more important than, for example, the words that don't have. So they should be recorded in the beginning of the test, just in case patient fatigue kicks in, and therefore the recording session needs to be cut short. So that will be it for my presentation. I want to thank you all very much for listening to it. If you have any questions, suggestions, or remarks, feel free to ask them now, later, or even send me an email. And well, that will be it. Thank you very much. And well, I'm open to any question.
Thank you, Sebastian. So, do you have any questions?
Yeah, I have a question. Thank you very much for your presentation. First of all, at what level do you do your analysis? So the Spearman correlation and the root mean square, is it at speaker level, at utterance level, at word level?
Sorry, maybe that wasn't clear. So here, the Spearman correlation, as I said here in the beginning, in the methodology, each speaker was asked to record a set of pseudo words, and then we performed the mean of those sets of pseudo words, and that corresponded to the intelligibility of a given speaker. So when I say that we use the different smaller subsets, the 16 pseudo words, we perform the mean out of those 16 pseudo words, and that obtain the intelligibility for that speaker given that subset.
Okay, yeah. And why pseudo words?
Pseudo words, we use pseudo words because they were also a registered, a recorded test within the context of the corpus, and it's because the words that when being perceptually transcribed, there's no prior context on what is being said. So, for example, if someone has already an idea of the word, they can extrapolate the rest of the word out of context. This happens. This is fairly common. For example, when giving intelligibility ratings for passage reading tests, that, for example, a given judge is already biased on the test because it already knows it. And therefore, the pseudo word, since there's no prior context, it corresponds to the exact transcription of what was being, what was listened or perceived by that judge. So in this case, well, the pseudo words, we thought they were interesting because we can decopulate them into words instead of using a longer file, and then work with the quantity of pseudo words to promote this reduction.
Yes, Pascal, if you want to ask a question.
Sure, I got a question. Like very, very cool talk, very interesting observation, especially that these double consonants have such a high impact in the oh, I hate this word. Yeah, you know what I mean? Yeah, I have to practice sometimes to pronounce properly. So I was wondering if you see some physiological explanation or some clinical observation why really like this factor of these double consonants might be so predictive, or is it just like some observation of what you find in the models?
Thank you very much. I think concerning, well, for me, it's more on the automatic aspect than on the clinical aspect of this part. I can say on the, have a more educated guess on the automatic part. But since this aspect was also found perceptually, I think it has to do with the co-articulations between consecutive consonants. And that, for example, as we listen to here, even for the mid-intelligibility patients, words that don't have any double consonant, they are still fairly intelligible per se. So since there's no co-articulation between consecutive consonants, at least I think it's easier perceptually to understand what was being said, and therefore it doesn't have as much as a discriminating ability between different levels of intelligibility than, for example, the words that have the dual consonant. For example, in this case, it was still highly intelligible, but in this case, the second R, for example, was not being issued, and therefore, I think among the different levels of intelligibility that we can find in a given scale, the co-articulations between double consonant promote a better discriminating factor between different levels of intelligibility, and that same aspect was translated automatically. And so I think it adds a bit more granularity to the way the system can predict the score, and that aspect was also proved perceptually. So in my opinion, I think it's due to that.
Yeah, no, so as a layman, to me, it sounds at least quite plausible, but yeah, no, thanks for the elaboration, makes sense. Maybe some follow-up, if I may, just a quick question. So like you said also in your justification or explanation why you use pseudo words, of course you do not have the context as you would have for real words. Did you, or like were the participants provided some, I don't know, kind of practice around each pseudo word? Because I think for multiple sclerosis, they, or like it seems to be common, like just trying to quantify multiple sclerosis from voice. I was reading into that a bit, and there they wrote for most tasks, for example, sustained vowels, that they like recorded practice rounds before like taking the recording that was then later on used for analysis. So maybe also for pseudo words, it could be a good factor. Like on one hand, if it's completely unknown word, then you read it, and even if you make mistakes, that might come into analysis. But on the other hand, like it might also, of course, be difficult to read in the first place, and then have some bias there, right? So yeah.
I'm not quite sure because I didn't do the recording sessions, but I think there were no practicing rounds because there were already a large set of 52 pseudo words. But I think, as you said, it could obviously affect if they had some training before. But I think the objective in the recording was to be as spontaneous as possible. I can search for the reference and send to you if you're interested. But I'm pretty sure that there were no training before, so it would be as spontaneous as possible.
Yeah, there was.
No, makes sense.
There was no training, but it was two modalities because they could read the word and also the therapist pronounced it before. So
yeah, that makes a big difference if they hear it pronounced beforehand. That's a good call. Yeah, cool. Yeah, thanks. Thanks a lot.
Thank you. Well, just to clarify a bit more, we also used pseudo words because during the context of my thesis, we are assessing different levels of granularity. So we start at sentence level, then we pass at word level, and then at phoneme level. And so the pseudo words stand more or less in the middle between the two, but we also performed assessments using other tasks as well. But for this webinar, in this particular context, we chose to present this part because we think the results are interesting, and well, it also gives a bit context on the words that are halfway through between the sentence and the phoneme.
okay, thank you, Sebastião. We can switch to Yulin.
Hi. Yeah, I will do the
Hi.
presentation now.
I think it's quite late in China, is it?
Oh, it's fine. It's just 7:30 p.m. So not that late. I'm wondering, can you see my whole slides, the presentation now?
Yeah, it's perfect.
Okay, great.
Thank you. You can go on.
Yeah, I will start the presentation. Hello, everyone. I will introduce myself. My name is Ili, and my supervisor is Professor Heidi Christensen. And the topic for the presentation today is using speech and analysis to detect, onset, and monitor cognitive decline. So, yeah. So first of all, I will introduce what is dementia briefly. And dementia is an umbrella term for a range of progressive conditions that affect the brain, and it can be caused by different kinds of disease like Alzheimer's disease and Parkinson's disease. And different causes of the disease can result in different symptoms, but they share the similar symptoms like speech and language ability decline, and these symptoms can exist even at the early stage decades before diagnosed in clinic. So in the UK currently, over 850,000 people are living with dementia, and and for dementia, it cannot be cured. So the early detection can ensure the early treatment, which can slow down and maintain the mental functions. Then what are the effects of dementia on speech? So it can be categorized into 3 parts, including the articulatory character, vocal quality, and the prosthetic character. And for example, so slow and So the slow and reduced articulatory movement of the lips and jaw is shown in the Parkinson's disease. And the larynx plays an important role in keeping breath and speak. So songs is generated in the larynx, and the muscles controlled in larynx can be affected by disease like dementia. And at the same time, so language can also be affected by dementia, and it can be classified into the word level and sentence level. For example, the vocabulary size, informative units, and number of words can be affected by the progress of dementia, and also the amount of the meaningful information covered in the sentences can also be affected by dementia. Then considering these symptoms, what are the current diagnosis procedures? Mostly the people living with memory decline will go to the GP first, and they will do some diagnosis, but for the GP diagnosis is not very accurate, and mostly the people will refer to the secondary care. And when they refer to secondary care, they will do the following, like shown in the slide: medical history inquiry, family interview, etc. This test for diagnosis whether the people is living with dementia or not. And in this whole progress, people may wait for a long time, and at the same time, some people may need to do some blood tests, which is invasive, and some tests is also quite expensive. Then could we do some automatic dementia detection? The answer is yes. And how could we do the dementia detection automatically? So generally, the clinicians or an IVA installed in the laptop can ask questions, and the people with memory problem will answer those questions, and speech is recorded in this process. Then the audio recordings together with the corresponding transcripts are analyzed with the automatic system. Then what I want to introduce is what are the typical dementia detection system. As shown in the slide, the typical dementia detection system is combined by the acoustic system or linguistic system or both. So audio recordings are input into the acoustic system for the acoustic-based dementia detection, or it can be input into the ASR system to get the transcript of those audio recordings, and then the transcripts are input into the linguistic system for the linguistic-based dementia detection. And for the very commonly used acoustic system, they are the pipeline systems, which include the handcrafted features as the front end and followed by a linear classifier. And so for the commonly used handcrafted features, it can be single acoustic features like F0, MFCC, I vector, or X vector. It can also be the very popular acoustic feature size like IS10 or compare, etc. And for the linguistic system, it's pipeline systems similar as the acoustic pipeline systems is also very popular. In addition to that, the neural language processing models like the language model of BERT has been proposed in the recent years for linguistic-based dementia detection. But what are the drawbacks of the currently automatic dementia detection system? So as we can see that promising results has been found in the existing dementia detection methods. And currently in speech and natural language processing fields, the technologies has progressed very fast. But we have found for the handcrafted feature or feature size, there are some restrictions for the single feature, and it cannot describe the symptoms embedded in the speech or language perfectly, comprehensively. And for the acoustic feature size, even though it can perform good sometimes, but considering different data sets or different conditions, it cannot keep consistent performance. So this, and we also find as we mentioned, deep learning technologies is very popular, but how to combine the medical knowledge with those deep learning technologies for making the deep learning systems not that black box is also motivation we want to explore in our research. And Another thing is for the current systems, they are mostly the binary classification for classifying the audio recordings or transcripts into people living with or without dementia. But this is not enough because there are also some people who's maybe mild cognitive impairment or functional mild disease, and binary classification systems is not enough. And we also find speech can also be affected by age. So whether we could explore the relationship between age and cognitive decline is also deserve to be explored. So in this presentation, the research covered the research I have read in my thesis, and in the thesis we have explored the following 4 research questions, and like how to apply the state-of-the-art deep learning technologies for speech and language-based dementia detection, and to what extent is possible to include more clinical knowledge for constructing the system and extracting the features. And the third is how to defining an evaluating framework and classification tasks that can be used in clinical practice. And as I mentioned just now, age and cognitive decline are confining factors. How can we design a system for taking these 2 things into consideration? And in the thesis, we have read in total 10 chapters, and it includes 5 experimental chapters. So for next several slides, I will introduce the research we have done for each of the chapter. First of all, we have done is proposing a hierarchical attention-based end-to-end system for dementia detection. As shown in the slide, is a very popular picture in dementia detection. It is named as cookie sift picture, and the people having a mental health problem, memory problem, they need to describe this picture, and their audios are recorded, and the audios are also transcribed into text for analysis. And while we have found the decline exists at both the word and sentence level, and the clinicians when they do the diagnosis, they take the words and sentence into account separately. Considering this medical knowledge, we designed an hierarchical system which can extract both the word level information and the sentence level information at the same time. In addition, we insert the attention mechanism at both the word level and sentence level for weighting the extracted word vectors and sentence vectors for classifying. And this system has got a pretty good result on the largest open source dataset in dementia detection, dementia bank dataset. And the next work we have done is designing an end-to-end system for extracting the data-driven acoustic features from the raw waveform. So for this system, is composed by Signite convolutional layer, by directional LSTM layer, attention layer, and a dense layer. So what we have done, as we have found as reviewed in previous research, the first layer for the raw wave speech is very challenging, as the raw waveform, it is high dimension and includes some noise. So we use Signet as our first layer, not only because it have less parameter to learn, and also compared with convolutional layer, it is more interpretable for the learned filters. And in our experiment, we have plotted the learned filters from the Signite to make the entrance system more interpretable. And what we have done is extract the features learned from the dense layer or attention layer as the learned features, and use a linear classifier for classifying the audio recordings from healthy controls or neurodegenerative disorders or mild cognitive impairment. And this research has also got a better result compared with the IS-10 and compare feature extracted by OpenSmell. And the third experimental chapter in the thesis is about extracting the high-performing acoustic features from the low-quality audio recordings. Because in the last slide, the research in last slide I introduced, we found even though that end-to-end system can perform better on the high-quality acoustic, high-quality raw waveform dataset, but it cannot perform very good on the low-quality audio recordings. So we think in this research, we want to explore how could we extract high-performing acoustic features from the low-quality audio recordings. This is the segment we from the dementia bank dataset, which we referred it as low audio recordings, and together with the manual transcripts, automatic transcripts output by the ASR system. And we found for the ASR system, it not only generates the transcript, it can also generate the time alignment information for each word and also the confidence score of each word. So we have found that for those words with low confidence scores, they are not with a very good quality, as it's hard to be described. It means it's not very easy to be understand. Then we refer them as the low quality speech segments. And also it includes a very long pauses. In this research, we hypothesize that the pauses and the low audio recordings are not necessary for extracting the high quality acoustic features. And under this method, we categorize the audio recordings into high quality, high confidence score, high quality speech segments and low quality speech segments. And we also find that by using the include duration, which means the high quality audio speech segments, and exclude duration, the low quality speech segments, and the included word numbers, which means the number of the words included in the high quality speech segments. We can design a three-dimensional acoustic feature, and by using this feature together with the popular acoustic feature set, namely IS-10 extracted by OpenSmell, we can get a better result compared with using the whole audio recordings for extracting the acoustic features. And in chapter 8, we have proposed a system which take the three classification scenarios into consideration, because we want to make the system more consistent with the clinical practice. Namely, we designed three scenarios named 4-way, 3-way, and 2-way. For this 4-way, it means we regard healthy control, FMD, MCI, and ND as 4 classes. Why we design these three scenarios? Because, for example, people living with mental problem, they with this design system, they can find FMD and healthy control and MCI and ND. So for MMD, they can just go to GP, and MCI and ND, they need to go to the secondary care. And for this design system, we don't introduce this one too much here, as it will be submitted to a paper, and we will introduce the last experimental chapters here. So yeah, the last experiment we did in the thesis is about using the age and cognitive status as two factors that can influence the acoustic information. And we found that both age and cognitive decline can affect speech. And here we use MMSE to estimate the cognitive decline. And for exploring the relationship between these two factors, we use PAROT, P-R-A-T, to extract two kinds of acoustic feature, namely the F medium and speaking duration here, and we plot these features from healthy control and people with cognitive decline separately. And we found that the weak inverse correlation between age and acoustic feature, between age and acoustic features for these for people living with cognitive decline and healthy controls. And we also found next figure, we use X vector as the acoustic feature, and what we have found is the relationship between X vector and MMSE with and without considering the age is different. When we take the age into consideration, the correlation becomes more. The correlation becomes most. The correlation becomes more higher. But if we don't take the age into consideration, the correlation score is not as large as the age-specific one. And under this estimation, we designed two systems. One is the end-to-end system, another is the pipeline system. These two systems are both the multitask estimation system for estimating age and MMSE at the same time. And we found when we estimate the age and MMSE at the same time, the system can perform better than estimate these two factors separately. Yeah, and these are this is the presentation today. Thanks a lot for listening. And if you have any questions, just ask me now, or you can email me by the email in the slide. Thanks a lot.
Thank you, Yirin. Are there any questions? I think you, Yirin, you told me you are defending soon. Are you?
Yeah. 1 week later.
Oh, great.
Thank you.
Yilin, I have a question. In the beginning, you mentioned, well, thanks also to you for your presentation. It's a lot of information, and that your thesis is finished and that you can defend it soon. In the beginning, you said acoustic system and the linguistic system. And the linguistic system uses the output of the automatic speech recognition. That's correct?
Yeah. Sorry, I cannot hear you very clear. So you mentioned about the linguistic system and
yeah. So that you said you talked about the linguistic system that uses the output of automatic speech recognition. That's correct?
Yeah, that's it.
So how dependent is, of course, the linguistic system will depend on the quality of the ASR output. If there are many errors in the ASR output, it will not function well. Did you have a look at that? How dependent is it? So I don't know if you can talk in terms of word error rates or something like that. But when does it break down?
Oh, yes. So thanks a lot for your question. Because the audio recordings are from people living with dementia, and the dementia bank data set we use for that system is not very with high quality. So it means the word error rate is quite high. I remember it's about 40% when we design that system. And yes, it will affect the performance of the system. And we also try to do some improvement on this method. As I mentioned, like the confidence score can be used as the criteria of whether, sometimes criteria for classifying whether the transcript words is correct or not. So in our experiment, we also explore if we only use the words with high confidence scores, how it will performance on the linguistic-based dementia detection. And we found that by removing those words with low confidence scores, the performance of the linguistic system can be a little bit better.
Okay, but I can understand this, but a lot of the NLP tools, for instance, part of speech tagging, I tried part of speech tagging myself on non-grammatical utterances, and then part of speech tagging doesn't work well at all. So if you leave out words, a lot of natural language processing tools, NLP tools, will not function well, I think. Isn't that the case?
So you mean use the part of words as the input of the system?
Yeah, so for instance, part of speech tagging, so I used for Dutch, we have two part of speech taggers, base different, but they function well for, let's say, normal grammatical utterances, but as soon as I tried them, use them with non-native speech or pathological speech, they fail.
Oh.
And if you leave out words with low confidence, well, I wonder, I think that might be problematic. Isn't that problematic then?
I didn't use the part of speech methods in my research, but I think that deserves to be explored as I have read some paper. They try to use the part of speech as the linguistic features, and it performs fine. But I'm not pretty sure. Yeah.
Thank you very much.
Thank you. Oh.
Okay. Are there other questions?
Yelin, I have a small question about the embeddings you are getting, right? You did a lot of embedding things there. So can you give a little bit more insight about them? You know, like you were extracting embedding with multitasking, you were extracting embedding with the other kind of trainings and all. So can you give a feel for the kind of features what kind of differences did it bring it in your improvement of the system or so on? Can you give some idea about that?
Sure. So thanks a lot, Matthew. I have tried to use the embedding methods on linguistic system, and what I have tried to use, like for that end-to-end system I proposed, I tried to use the GLOW pre-trained word embedding and also the random initialized word embedding. And for these two kinds of thing, I also try to set the GLOW pre-trained word embedding as fixed, and we don't train it in the system, or we can make it trainable in the system. And we found a pretty interesting thing, like for the automatic transcripts. So if we use the, I think for the manual I cannot remember, like for the pre-trained GLOW embedding, which can be trained, that can perform the best. And for the GLOW embedding, which is fixed, the performance on the manual transcript and automatic transcript, it performs various. It means, I cannot. Let me find my experiment. A second, please.
Mm-hmm.
Yeah. So if we use the manual transcript and it is trainable with the GLOW embedding layer, GLOW pre-trained embedding layer, it can perform the best. And for the automatic transcript with the GLOW pre-trained embedding matrix, and it is also trainable. It also performs the best among the automatic transcript. But for the random initialized embedding layer, which is trainable, compared with GLOW embedding layer, which is fixable, we found the randomized embedding layer, which is trainable. It can perform better than the GLOW embedding layer, which is fixable. But the situation is different for the manual transcript.
Okay. So
Yeah.
I also have a question regarding, because you did embeddings which were coming out of linguistic, like the output of ASR or manual transcript, but you also had embedding that you learned through acoustics, so can you tell a little bit like how complementary, how different this kind of acoustic embeddings, where it was more useful for you, or like how did it bring, what kind of complementary information like the acoustic embeddings were bringing to the linguistic embeddings, linguistic feature based embedding. So can you give a feel for that?
I think for the acoustic embeddings, as I found from my end-to-end signet-based system I introduced just now, I found that actually, so it restrict the audio recordings should be pretty the quality of the audio recordings should be pretty good. But if we have a pre-trained acoustic system like wave to vector, actually we can get a very good performance on the on both the low quality acoustic audio recordings or high quality acoustic recordings. So even we found sometimes for the acoustic systems, it cannot perform as good as the linguistic system, generally speaking. But if we can use a pre-trained like wave to vector, sometimes it's the acoustic based system can even perform better than the linguistic based system.
Okay, thank you.
Yeah. Thanks a lot.
And all the best for your defense.
Thank you.
Yeah, maybe you can send the mail around so we can, yeah. Is there a part that is public for on your defense?
Sorry, you mean?
Is it public, your defense, your PhD defense?
It's on the 10th of May.
Okay.
Yeah.
And is it possible to attend it online or via Zoom or something like that?
I'm not sure. I can check with Heidi about that.
I don't know. There can be a component, I think, that can be public. I don't know. It depends on the place, I guess. I think like Edinburgh has a public component, and then a question goes private. And so if there's a public part, perhaps you can share it to others,
Yeah,
Yeah.
I'm not really sure about that, but yeah.
I know, for example, Srikanth, I think, has a public presentation, part of the presentation, which can be public. And then there will be always a question answering part, which goes private sometimes.
Oh.
Yeah. Yeah. Good. Thank you. I think I must thank the first speakers of the TAPAS webinars, Sebastian and Yelin. And thank you very much for the presentations. And I hope to see you all again here. And I give the last words to Julie. A small applause for the people who have presented for this.
Yeah, thank you, everyone. Thank you, Sebastian and Yilin, and see you next Tuesday at 1 also. And in the meantime, I'll try to put the recording on the TAPAS YouTube channel. So
yeah.
So have a good evening and see you next week.
Thank you.
Bye.
Yeah. Bye.
Thank you. See you next week.
Bye.